Good evening, everyone. Welcome to another episode of our remote scanning webinars. We've been in Germany on the last episode, and now we moved back to United States, where we're going to finish our series. So today we have Derek Rishel from United States, and the next episode and last one will be next week. Also, a guest from United States. The only thing is we had to change the episode date for next week. Instead of Tuesday, it's going to be on Thursday the 5th. So we'll do a post about it, but just so everyone knows. So I just wanted to say welcome to everyone. Thank you for coming to another event that we are broadcasting live. Just to make sure everyone understands, we need everyone to have mics off and cameras off throughout the whole time. If you have any questions, just pop them in the chat. We'll use those questions to ask our guest today. And I want to welcome Derek Rishel. Please say hi to everyone. It's a pleasure to have you here today, man.
Hello, everyone.
So Derek is one of the big names on remote operations, at least from my perspective. He has a lot of experience with remote operations in US. And of course, he has many years, I would say 2 decades at least. Derek, correct me if I'm wrong, within
That's
radio.
correct.
So do you want to introduce yourself a little bit for those that don't know you yet, what you do, how you came to be here today with us?
Sure. No, I'd be happy to. So first of all, I just want to say, Sam, I would say when it comes to the remote scanning community, you are also one of those people that have a lot of influence. And so, I really appreciate both you and Julian inviting me on to this series to be able to talk about it. So it's very much appreciated. I know we've met in person, Sam, you and I. Hopefully, I'll get to meet Julian in person sometime soon. So my journey, so I started as a phlebotomist, actually. I was working at a small rural hospital. And on the weekends, I would spend my time calling MRI patients and doing pre-screening. And so I did that for about a year. And then one of the patient coordinators that worked for the mobile system that would bring the mobile MRI to our rural hospital had just finished X-ray school, was moving into become cross-trained as an MRI tech, and so asked me, would I be interested in joining at that organization as a patient coordinator? Small bump in pay, and at that time that was really important. So I made that move, and I really just, as I was exposed to the modality of MRI, fell in love with it. So in high school, had always done really well in math, had done really well in science and physics, and enjoyed that part of education. And so realized kind of shortly that I had a passion and a knack for MRI. And really, even as a patient coordinator, while other technologists I would be working with in downtime would jump on their phones or jump on Facebook or something, I would usually just grab a user manual and start reading. Not because just for the sole reason because it was interesting to me. And so uh, that put me in a position, because our company was growing rapidly, to be able to, even as a tech assistant, kind of train new techs as they would come on, because I understood how to scan a runoff, for example. I couldn't sit down at the scanner and actually do it, but I understood it. I understood how to optimize protocols and use the different imaging options available to improve imaging. And so I worked as a tech assistant for about 4 years as I kind of went through X-ray school. The last X-ray I ever took was my very last day of clinicals. I knew I didn't want anything to do with X-ray. MRI was my home, and so I moved into that modality right away. So I became a tech, scanned as a tech for a couple years, and then we had the opportunity within Michigan, which is the state where I lived, to have an application specialist that provided training for the 2021 mobile MRI systems that we had in the state. So we had a pretty even mix between Siemens, Philips, and GE. And so I provided all of the training for those systems. That was my book of business.
That's
As
good.
part
To
Go
There's two
ahead.
things
Yeah.
I want to point out, actually. They are very important. Sorry to interrupt you. One of them, it feels like you started as a local tech from, if you see it from the perspective of remote operations, where you've been,
Hmm.
it feels like you were a local tech, right?
I
And
was.
another important thing is the fact that we've been having these webinars, and every single one of our guests have a completely different story, how they got to remote operations. And it's super
Yeah.
that you started as a phlebotomist and you went through tech aid and you went through x-ray school and all of those steps. It's really important that everyone can see, that everyone can get to the remote scanning panorama. It doesn't matter where they're coming from. So thank you for sharing that part of your journey as well. It's very important.
Yeah, of course. Yeah, everybody has a journey, right, Sam? Everybody has a story, and so it's kind of interesting to see how we've all gotten to our this point on our journey. So, as an application specialist, one of the things I would do was kind of kick off or pilot new programs. And so, one of the programs, this was roughly, maybe I guess it was almost 4 to 5 years ago, was we wanted to pilot with. Siemens, the remote scanning solution. So for the mobile on the mobile side, I started that pilot. At that, probably 2 or 3 months into the pilot, my wife just got completely sick of 6 months of overcast skies that we lived in Michigan, and so we decided to move to Florida. So when I moved to Florida, was still kind of maintaining that pilot on the fixed side of our business, but with Acumen the majority of, or on the mobile side, but with Acumen, the majority of their fixed business was in both Florida and Texas. And so once I moved to Florida, um, took over the fixed pilot that was already kind of occurring with Philips. And at that time, the Rock solution, this is 4 years ago. At that time, that solution was the only one that was truly kind of multi-vendor. And because our install base was so diverse, that kind of dictated who we ended up choosing. I mean, there was only really one solution for us at the time. So took over that pilot, kind of spun that up from pilot phase to being installed at every single scanner across our fixed fleet that was
This
compatible with.
this is with Acumen, right?
That's right. Yeah. So every single scanner that was compatible with that solution, we installed, and then about 20 of the mobile systems we installed and started um, remote scanning operations. So that's kind of how I got from phlebotomist to remote scanning program director.
No, that's awesome because I follow Acumen. I think was one of the first companies that I heard when I was researching about remote scanning a few years back was 𝐓𝐴𝐷 and Acumen, and
Hmm.
I didn't know you were part of it until later on, and I think you were
Yeah.
already out of Acumen. So for those that don't know the company, I'll write it on the chat so you can have a look at it.
Yeah,
Can
and we worked with 𝐓𝐴𝐷 and Pete and Neil and that team who did a phenomenal job, for us as partners in providing remote scanning solutions to our patients.
It's one of the things that I really like, Derek, is the fact that most of the communities within radiology, they're very dispersed. They don't actually come
Hmm.
together. But when we're talking about remote scanning, you have companies like Acumen and Alpha that could be competing with each other, but they chose to work with each other. And we have this kind of relationship throughout all the countries that I'm aware they have operations like this. Is this something that you experience as well in the United States, or is
Yeah, I
just
mean,
case?
to your point, Sam, remote operations is a very, very small world. Like, so I have a lot of colleagues at what would typically be seen as kind of competitors in the field where we collaborate and share insights because we're trying to help each other win,
Yeah.
right? So it is kind of fun when you're in a niche and in a startup kind of field that you're able to collaborate with people, share insights, um, and provide that guidance to each other to help each other succeed in the space.
That's a nice way to put it, and also a nice segue for what I was going to ask you after, because as you said, this is a brand new niche, right? There's not
Hmm.
many people doing it, not many people are aware of
Yep.
what it is. That's why we're doing these webinars to increase the awareness. Um, how is it for you to work as a consultant? Because you are a consultant now in terms of remote operations. You have your consulting company as well. If you want, we can share the link here for people to have a look as well. How is it for you to consult in such a small niche where there's a lot of pushback? How is your day-to-day life? Because it might not be easy because there's so much pushback. I know in the United States it's
Yeah.
not as bad as it is in Europe. You guys are quite open to it. You've been living that for a few years. In Europe is a little bit more new. So how do you feel that being in that niche as a consultant?
Yeah, so I mean, at first, several years ago, Sam, it was really kind of the wild, wild west. So there was really no guidance or regulation either permitting or prohibiting really any kind of remote scanning guidance. So every company was just kind of doing what they felt like was best for their organization. And there was really no kind of regulatory or compliance piece um, or standard of operation that anybody was really being held to other than their own internal kind of policies and procedures. So from a um, director or kind of operations side from a facility, I would say the most common questions or objections that I run into in regards to kind of lack of information is what does it look like from a regulatory and compliance standpoint? Like, what are the hurdles that we're going to have to clear to be able to provide this service at our facility? And then, secondly, like injection policy and coverage. So who can inject, what kind of role or scope of practice does that person have to be able to give contrast if they're on site as a tech assistant working with a remote tech, right? So those, from an operations perspective, those are always the two most common questions that I get that come from a kind of lack of knowledge in the industry. I think from the technologist standpoint, it's always one of three things. First is, am I going to be replaced? Like, are we doing this because I'm, are we doing this and I'm going to lose my job? So if one tech can scan on multiple scanners, which means there's a need for less techs, does that mean I'm going to lose my job as a tech, right? Um, Another one is, can this be done safely? Which I'm sure we'll talk about probably at some point. But for me, that was the biggest hurdle. I've been an MRI tech for a long time. I've been an MRSO, and with a lack of any kind of information out there around process and procedure or standard operating procedures on remote imaging, like, how are we going to do this safely and make sure that we're protecting patients when we're removing the technologist from the point of care? Like, what does that look like, and how are we going to be able to do that? So that's one of the questions. And then the last one that I get from technologists typically is, uh, will I be liable if something happens to the patient? Right? So
Yeah, I think
what does that look like?
liability is a big one for sure. Yeah.
Yeah. What does the liability look like? Right? So those are when I'm filling in the missing pieces for organizations as a consultant. From an operations standpoint, it's regulatory, it's injections. From tech standpoint, it's how do we do it safely? Am I going to lose my job? Et cetera. So and it's been really helpful to be parts of boards like RSQS, part of the board that helped draft the standards of for remote scanning for RadSite. So having input, one, and then hearing other thought leaders in the space bring their ideas to the table has been hugely valuable in shaping the opinions that I give to facilities in how do you move forward responsibly, and how do we do this well?
Yeah, I like the word responsibly there because I think you have a big responsibility as a consultant in a brand new field when you advise these hospitals because you basically one of the pioneers as well, and you're telling them how you believe is the best way to work. The workflows, as you said, standard operation procedures, all of that. So you also have a lot in your shoulders in terms of responsibility when it comes to advising these hospitals. I'm going to ask you a question that Johan van den Brink, I hope I said the
Sure.
name, ask you just, would you like to see more content coverage in the standards? He's talking about the standards to regulate remote scanning. What should be the priorities there? And the second part is from the question is from the other angle, what would be your biggest concern if it comes to over-regulating the space? Let's say, what would you add to these standards in order to regulate remote operations? And what would be the main problem if they over-regulate it?
Sure. So I think what we're going to see within the next couple of years is standardization from the regulatory bodies around what this looks like. So that's in the United States, the sites or the accreditors that are compliant with CMS are ACR, IAC, and RadSite. And so right now, Sam, they've all issued guidance around what remote scanning should look like for their accreditation, and they're all vastly different.
Yes.
So getting some standardization between those three bodies so that there's less confusion in the industry around what does responsible remote scanning look like and how do we do it correctly, I think is the answer to the first part of the question. I think the answer to the second part around overregulation. So I'm not going to mention which of those three. You can, pull their regulations and read them yourselves, but some of them in their current phase completely prohibit full remote operations, which I'm completely against because that takes one of the most valuable use cases of remote imaging in being able to help organizations with their business continuity and continuity of care and reduce backlog times for patients and improve patient quality and experience, and it removes that from the equation. So my fear on overregulation would be that the pendulum swings too far to that side, which would kind of disallow or severely hinder the ability to be able to do full remote operations.
And I think we are seeing that already with, for example, the guidelines from ACR. I don't know what's your opinion there, but when we read
That
those,
was the unnamed. That was the unnamed one that
yeah,
I had mentioned
I
to you.
think
Yeah,
we can talk about it because I read it as well. And when I read that, I was like, okay, these guys don't want remote scanning to happen at all.
right.
And you have like the Brazilian College of Radiologists releasing their
Mhm.
own document as well, which is, I don't want to say it's a cheap copy of the ACR manual, but it's
Yeah,
something like that. So I can see some people are putting guidelines out there, I think for now to just everyone hold their horses. We have something
right.
here. We're going to regulate
Well,
a little bit further down the line
yeah.
in order to
And
allow it.
two things interesting around ACR. So I know we know all of the players in the remote scanning community. They are the experts in how this should be rolled out.
Yeah.
From what I understand, ACR didn't engage any of those experts. And so what's happening is um, many facilities are leaving ACR and adopting the RadSite accreditation because it allows them to be able to operate with full remote operations and take advantage of that use case. So I think there's benefit there because the community, the industry is pushing towards full remote operations as a needed use case. And I think that's going to force the hand of some of these accrediting bodies that have maybe on their first attempt put out something that's a bit too prohibitive.
I want to ask you something in terms of this as well, because hospitals without guidelines and without regulations, they probably will turn to you as a consultant, as an expert on remote operations for some advice, right? How to implement them,
Sure.
those SOPs, all of that. So
Yep.
you help hospitals as well assess and design and implement remote programs. How does that actually look like when you're doing like a project with them? What do you actually assess, and what do you actually go to them and say, this is what you should use because you can incorporate with this thing? Do you have any examples that you can give us how to approach that situation?
Yeah, so that's the nice thing about consulting, Sam, is once you've built the program, it works for the most part for just about every facility. So all of the hard work was really done in the first few months as I was putting together all of the information. After you've put it all together, it's really walking through that end-to-end program plan that's been developed with each location, helping them tailor it to best meet their needs. So step one is always, it's really kind of five, I've broken it down into 5 steps, and I'll just run through them kind of briefly if that's okay.
Yeah, please.
So step one is always kind of identifying the opportunity. So it's kind of an analysis phase where I just gain understanding of what does success look like for your organization? Because believe it or not, it varies drastically from one facility to the other, what they're trying to do with their remote scanning, program. So gain understanding, then work through with your legal and your regulatory and compliance team. What are the regulatory and compliance hurdles? Who are you accredited with? How do we manage those once to work towards those KPIs that we've kind of developed where we've identified success? Next is kind of which solution is going to work best for your install base. So every facility that I work with has kind of a unique install base. Some might be have all their systems from a single vendor. And so sometimes there's advantages to working with that vendor because they have other more comprehensive kind of programmatic approaches that can benefit the remote scanning. But really kind of working through
Sorry to
what's the
sorry to
best
interrupt
solution
you.
to use. Oh, sorry, Sam, go ahead.
Oh, sorry to interrupt you. It's interesting that you're mentioning that because some hospitals, for example, might have just Siemens scanners, and it makes
Mhm.
sense to go with their solution. That's what you're saying. And we're gonna touch upon this point later on, if you can
Yeah,
expand that a little bit later. So
yeah.
you mentioned identify the opportunity, legal and compliance, which solution works better, and we're missing two. What's the last two?
Yeah, well, this is just kind of on the identifying the opportunity. So this is actually just the first phase of the 5 kind of phases of the end-to-end program. So the last thing that I do kind of in the analysis portion where we're identifying the opportunity is do some pro forma modeling. Because I don't know if you've experienced this, Sam, but a lot of times facilities are coming to me with the assumption, the false assumption that uh, there's going to be a huge savings on the expense side by rolling out a remote scanning program.
Yes, if you're approached by a manager, that's always the first thing they have.
Right, right. Yeah. And typically that's not the case. I mean, once you factor in the wage for the remote tech, the wage for the on-site tech assistant, the cost, the subscription cost of whatever platform that you've chosen to utilize, um, unless you're doing really 3 systems simultaneously, it's a net, it's a net, it's even or a net loss on the expense side. It's really more about revenue generation, about being able to expand days of service and hours of service for facilities that have maybe closed their magnet because of their staffing gap, right? There's so many facilities that I've worked with that have unutilized or underutilized MR systems because they just don't have a technologist. So
Yeah.
it's really more about building the revenue opportunity than tackling the expense side. But that's an important piece to kind of level set that expectation at the beginning of the project so that they understand this is what it's going to look like when you model out the pro forma.
Do you normally run, you are invited to consult on pilots as well, for example, should I run a pilot on this platform, or should I run a pilot on that platform? Are you called often to compare which one they should use?
Yeah, I would say so from vendors, no. From facilities that are in a pilot, yes, that's happened. That's happened often, Sam, where a vendor has sold them a platform, but the site is failing because they never had someone develop an end-to-end program plan that's really strategically walking them through the adoption and utilization plan for the platform. So I get calls from facilities that are in pilot phase, facilities that are looking to pilot. I would say the majority of people that reach out have an interest in, but haven't started the pilot process yet. So I often work through the pilot program, helping them establish, these portions on the analysis kind of phase.
Okay.
Um,
Just so everyone understands, a pilot is basically a period of time where the client is using a platform to test if it works or not according to their needs. Correct me if I'm wrong, but that's how
that's no, you're
that's
absolutely
basically a pilot.
correct. Yeah, and those are usually 3 to 4 months, sometimes a little shorter, sometimes a little longer. Often the vendor is allowing them to test on a small scale, but test for free with the hopes that they're going to be able to move them to agreement once they've proven out the benefits of remote scanning,
Yeah,
right?
that's pretty standard here in Europe as well. That's normally how
Yeah.
it just free, well, let's say 2 weeks or sometimes 2 months. It really depends how the manufacturer or the platform wants to sell it. I want to ask you something in regards to this because you developed that program. What are the key success metrics that you have there when you assess the performance of those platforms? For example, you went to a hospital and they asked you, can you compare these two platforms? What do you advise for our case? Which one we should use? You say, okay, you try to go with A or B. How do you measure the success of your opinion in that situation?
Sure. So sometimes it's that choice is really dictated by their install base. Not all of the vendors provide backwards compatibility across all scanners. So sometimes if a facility has a scanner that has kind of legacy software version, that's going to reduce the number of solutions that may be beneficial to that facility, right? Then we look at pricing. So what does pricing look like for each of these solutions? What kind of additional benefits are included, if any, if you're looking at a more of a larger programmatic approach, which I think we'll talk about a little bit later. But as far as KPIs that I really work with facilities on, they almost always fall into two categories. So the first one typically is operational excellence KPIs. The second is clinical excellence KPIs. So on the operational excellence side, we're usually looking at utilization rates. So are these service hours increasing on each imaging system? Are we able to utilize our remote techs to improve our magnet utilization across our organization, right? So that's usually number one. Number two is usually kind of some type of operational cost per scan. So are we able to drive down cost per scan by eliminating travel techs or temp techs or overtime, kind of, et cetera, in some of these other ways that we've chosen to try to tackle our staffing shortage. The final one is for operational excellence is some type of technologist efficiency measurement. So are we able to increase the number of scans completed per hour per tech?
Okay.
So it's usually from an operational excellence standpoint, as far as KPIs go, it's usually some variant of those three measures. And sometimes you are limited a bit by the data that the site has on hand for measuring. Sometimes you have to kind of work with their operations team to be able to build out the data that we need to really assess that well. But typically, that's what we're measuring on the operational side. On the clinical excellence side, it's usually like risk management statistics, right? So safety incidents. My perception when we launched at Acumen was we're going to see a higher incident rate
Mhm.
of safety events when we have tech assistants managing the patient care as opposed to technologists. That was just my assumption, right?
That's a
Without any
common
kind of
fear. Yeah.
with any kind of data. What was that?
I was saying that's a common fear that most people
Yeah.
have. Most people that actually come to these webinars, that's a common fear.
Yep. Yeah. And so what we found was, which was startling to me, was that we actually saw fewer reported incidents of MR safety, which resulted in, like, patient injury, or just even if it was short of patient injury, if like patient walked in the room with something in their pockets, right? We saw less reported incidents, and I think the reason was largely due to the training that we rolled out and our policies and procedures on how we moved forward with patient care. Allowing at the majority of our facilities, they were single tech staffed. So one technologist would go out, question the patients, bring them in, get them changed, get them on the table, get them off the table, et cetera. It was just one person, right? When we're working remotely, we have the tech assistant that's doing all of that, but then also we have an additional set of eyes that's looking over the screening form, that's looking over the patient order, and then that's reviewing all of that with that tech assistant prior to the patient ever walking into the scan room. So I think just in the fact that you have two sets of eyes reviewing the screening form and the patient and their procedure, as opposed to one, is what helped really steer or improve our incident rates when we moved to remote scanning. So that was really interesting.
That, that's
Um,
that's interesting they mentioned that for sure, because most of the operations that I know, they report the same thing, that they feel like
mhm,
it's safer than it was before. And that's one of the things that I actually defend on my presentations, that remote operations actually make it safer than what it is, just by looking at the sheer amount of hours that the local tech has in training for safety compared to a normal
right.
MRI technologist. Because let's be honest, I also did a poll on this. I also contacted a lot of universities around the world, and I spoke about this openly. And most of the universities have zero to no training on MRI
Mm,
safety. So you, as a
yeah.
technologist, go to work on that scanner, and you learn for someone that was next to you, or you probably went to buy a skill or canal course, and you learned something during 3 days. But these people, they are having weeks of training on MRI
Mhm,
safety. And as you said, on top of that, you have someone at home or in the hub or whatever they are, as a double set of eyes, just checking everything once again. I think one of the problems for people to understand that is we do this and we talk about it, but we never show it. I think there's a lack of that kind of showing how that actually works, like a live demo or something like that, because it will be way better for people to have that visual effect, seeing a operation roll out actually in front of their eyes. Because we talk about it over and over, but it's really hard to understand a concept that is completely new and they've never seen it. So I think that's one of the main problems in accepting that safety actually can be improved with remote. I don't know if
Yeah, and
you think that, but
what I would love to see, and what I started to work on at Acumen before I left, was let's publish a study which really takes the data, because we had a lot of facilities that were still doing legacy kind of one-to-one imaging because their units weren't compatible with the remote solution that we had, and take that sample size from the text that we're doing, or the scans that we're doing remotely, and let's compare those over time. Let's publish that data and provide something, so that, because right now all of the uh, it's just an opinion. Like, it's just an opinion of this is how it's working. This is our perception of how it's working. If we could provide some data to actually drive data-driven decisions around how does this work? And if we are seeing remote scanning safety incidents, what are they? What's the root cause analysis? How do we improve? If we're seeing improvement, why is that? How can we integrate some of those best practices into what we do in more kind of traditional scanning? I think there's a huge opportunity for a provider to be able to have an impact on remote scanning by publishing a study like
Yeah,
that.
absolutely. I think the only article out there in those terms is from University College of London.
Mm,
I have it on my presentation as well. They did a trial with cardiac MRI, and it was so successful that the NHS is trialing it again, and they intend to roll out if the data, as you mentioning, it's actually good enough. I have one question for you that it's quite important, but before that, hi Julian. Julian, I want to say hello to you.
Hello. So sorry.
I know you've been on
Again,
the background.
fighting with London traffic. Anyway, I was listening in the background. Fantastic conversation. Thank you, Derek, for providing the insights. And I would say, as you mentioned, Sam, it's very nice that we always have different background because each one contributes in a way to understand a little bit more how remote scanning
mhm.
fits the different background and different stories of everyone. I actually have quite a question. I would say quite a probably an unusual question, but it came to my mind while Derek was talking about reporting, and you mentioned it as well, Sam, that there is this conception for which safety might be improved under the remote scanning umbrella. And I was thinking, Derek mentioned something that triggered my mind. He mentioned that actually the reporting of different accidents kind of like decreased, if I understood correctly, now that we have remote scanning. So about reporting, because us as radiographers, still, even those that are a little bit more seasoned, they tend to be sometimes a little bit reluctant, a little bit, I don't want to say discouraged, but they are not kind of like encouraged enough to report the different accidents for many reasons, like blame culture. But still, now the more we get involved and the more we understand the importance of reporting, the more we work in MRI. So, how do you instill that same mentality to a tech aide? Someone that, let's say, maybe never like worked in MRI before. How do you kind of like promote this type of mindset? Because I don't want to say now that the number of incidents is maybe less because they don't have this type of mindset of reporting the actual incident, but how do you kind of like encourage this type of mindset even someone that hasn't worked much in MRI?
Yeah, so that's a great point, Julian. And I would say, and I think Tobias would agree, the number of safety incidents is dramatically underreported, right? Either facilities don't want to put their names out there as having had a safety incident. Technologists are concerned about retribution if they were responsible for some type of safety incident. So I think when it comes to really getting a good comparative data set, uh, there's going to have to be kind of two buckets. So the first one would be to the tech assistant and to the tech, hey, these are never events. These are things that can't occur. And if they do occur, there's for sure going to be some kind of disciplinary action because you've taken a not a Ferris wheelchair or a non-conditional pacemaker or like those kind of events that are sentinel events or events that could cause patient death, right? Like those have to be never events. Those are going to be reported every single time. You're going to get in trouble if you do one of those, right? But then there's also all of the safety events, like the patient had a IV that went sub-Q, or the patient got really hot while they were in the scanner, or the patient had an issue because we didn't put padding alongside the bores good enough, and they got heating or a burn. Like those kind of incidents that aren't sentinel events, I think you have to give for both sides, the ones that are doing legacy scanning and the side that are doing remote scanning that you're looking to collect the data from, make sure that that team understands that when you report this data, you're helping us build best practice that's going to provide you the policies and procedures you need and the training that you need to do your job more effectively and more safely. So as you report these things, it's not a negative where we're going to suspend you or fire you. It's a positive. We're going to take that and we're going to learn together on how we get better over time. So part of it is just, I think, helping the tech and tech assistants understand that you're a human being. Mistakes are going to happen. That's okay. Let's learn together, right? There's a huge stigma like you can't make a mistake, or it's not acceptable. And we're human. We're going to make mistakes. Remote patients are going to get injured. Legacy, patients are going to get injured. It's going to happen. But we don't get better unless we report the data.
Derek, this is a fantastic answer. I just want to follow up to my question as well, because someone introduced another very interesting point, Joanne, actually.
Can I just add something just really
Yeah.
quick before you do
Yeah.
the rest? So basically, I think that tech aides also come into this field with a clean slate. So when they come to learn about safety, and we're going to talk about safety a lot on the next episode, but when we talk about safety with these people, they have no clue, most of them. So we have to instill in them the importance of reporting, as Derek was saying. And I think they will assimilate it way better than us because we've been working in this environment for so long. We are like, okay, it's just a coin that flew, who cares? But for these new people that are new on the field and they are completely new to safety, for them will be a big thing. So the way we train them is like, if a coin flies, it can actually damage the magnet. It can do this. We have to report it. So I think it's easier to teach them as well than teach a 10-year-old radiographer that has been doing MRI for a long time. Sorry to interrupt.
Yeah, that's a great point.
No, of course, of course. I think Joanne about this was actually asking, and this is actually one of the questions that was coming to my mind as well. Who is going to be the one reporting in at the end of the day? Is it going to be, could be both, could be mainly the task of the radiographer, the MR tech, or would be the one on site, the person on site, perhaps reporting potentially incident? Is there any guidance at the moment on this?
Derek, I'm curious for your answer because I have my own, but I want to hear you the guest. So
yeah, well, Sam, I might defer to you because I don't really have an answer for this one outside of, I mean, for me, even if I'm scanning remotely as a contracted employee, so I'm not I'm a 1099, I'm a contracted service, right? I'm not a employee of that facility. If an incident occurs on my watch, I'm going to want to report it because I'm going to want to get better to make sure that the mistake that just happened doesn't happen again in the future. And unless we're learning from our mistakes, it's going to repeat itself, right? So whether I'm the tech assistant, I'm the remote tech, I'm the contracted remote tech, I'm going to make sure that we report what happened. That's my opinion. That's just my opinion.
I just will add one thing. People, I think, start to forget that the remote and the local, they're a team. They're not two different people doing different jobs. They are a team working together. And I think that's very, very important because we kind of forget that. We're talking about, oh, it's a remote operator is doing whatever he's doing there, and I'm local, I'm doing my thing, I don't care. We're still working as a team. So when you work as a team, both of you have to report on these incidents from both sides, either because it's an active safety issue or a passive safety issue. Let's say you're scanning without padding, you as a radiographer or technologist scanning at home are responsible for alerting the local technologist that that patient doesn't have padding. That local technologist is also responsible for not putting that pad. You're a team, so you have to work as a team on,
That's right.
on both sides. I would like to deviate from safety for now because we'll have a lovely webinar next week with Geraldine, and she's expert on remote operations safety training.
Yeah, she's great.
So let's move in another direction because today we're talking about, and I'll let you speak, Julian. We're talking about multi-vendors, and I want Derek to focus a little bit on that. But before that, Julian, go ahead, please.
I want to help you deviate a little bit. I know it's a multi-vendor thing, but I have one final curiosity to ask Derek. Being a consultant, I think he must have like a strong point about this, because I always try to bring to this webinar some personal examples of real stories, and I want to bring this one. For instance, today I was speaking with this colleague who was mentioning, and you mentioned Derek quite extensively about the operational side of thing, meaning the possibility of get, some, I don't know, extra scan performed, perhaps even like during extra hours. And we get an example here in the UK where they are already working extra hours, I think from 8 to midnight or something like that. And we were exactly discussing about this. And his point of this radiographer that he's still not quite confident about the remote scanning work, he was like, well, but at least I will have the benefit of working from home. And this is one of the things that comes almost immediate, the idea, yes, I can do it. I'm happy to work until midnight, but at least I will do it from the comfort of my house and everything. So
Mhm.
how do you actually explain to radiographers and MarTechs approaching for the very first time remote scanning that yes, there is some flexibility, but they will still need to, attend, their workplace, which this time will be potentially a hub?
Yeah, so when remote technologists express interest in remote scanning, I think, Julian, you're 100% right. It's almost always around, can I scan in my pajamas? Right? That's where they want to be. That's the exciting thing. And I can't blame them. Like, in the history of imaging, has working from home ever been in the career path of any technologist? Like, not really, right? If you wanted to work from home, you had to become a manager. You had to become a director, and then you could, maybe do some work from home. So that's definitely where the majority of interest I get from remote technologists that are reaching out to me independently. Hey, what do I have to do to work from home? What are the opportunities? Um, once once in real life, when I've seen this be executed, most facilities are adopting some type of hybrid approach. So sometimes they're allowing, maybe 2 days a week, they're allowing technologists to scan from home, but then they're also requiring them to come in and scan from maybe kind of a centralized command center where all the technologists come scan from, or they're having them come and actually scan kind of in that legacy model one-to-one, especially as they're first ramping up their adoption and utilization of remote imaging across their workforce. So they might be allowing people to scan remotely from home a couple days a week, but then also are asking them to come in. And what I'm finding is that most technologists want the ability to, or at least the option to be able to continue to scan in a hybrid environment where they scan remotely sometimes, whether that's from home or from a command center, but then they also still have the opportunity to scan in front of the magnet, being the primary point of care, taking care of the patient and getting those good feels that we get as technologists from providing really good care to a patient in person, right? So I think I don't know if that answered your question, Julian, but
Yeah, yeah.
that's
In a way, yeah, absolutely. Yeah, no, I understand it's very tricky to be honest to find the right answer, even because, especially because it's still quite don't want to say like a new area, but everyone is trying to understand a little bit how it works. Anyway,
yeah, it's quite fluid. Yeah.
let's go back to the multi-vendor, otherwise Sam is gonna kill.
No. It's just because we have a strict time for Derek as well. He has other commitments. Derek, let's go straight to the point. That's one of the reasons why we wanted to talk to you. You worked with many vendors, many platforms, and that's one of the things that people are not so aware of, that as a remote operator, you might have to use different scanners, but also different platforms. You might need
Mhm.
a Siemens one or a GE one or a Philips, or it doesn't matter, Roclab. So what are can you compare them, like their strengths and limitations for the major systems? Is there something that you'd say, okay, my ideal system would have this from that one and this from that one? Can you paint a picture for us about the different?
Yeah, no, for sure, Sam. So that when I'm on that analysis phase of creating an end-to-end plan, this is kind of step 1D, right? Is let's take a look at all of the solutions. Let's talk about their benefits and their limitations, compare and contrast, and then determine which one is the right one for you. So I have experience on Siemens Virtual Cockpit. I have experience on Philips Rock. I have experience on GE's 𝐸𝐴MD Lite. I have experience with 𝐓𝐡𝐞 Live and RoClub's both their connector and kind of their marketplace. So I have a pretty good sampling, at least from systems that are utilized in the United States. I have a pretty good idea of the benefits and limitations of all those. I think instead of calling out limitations, and they all have them, right? Every vendor has their own limitations. Every vendor has their own strengths and benefits that are kind of unique to them. So I think the best way and the thing that might be most beneficial is just walking through, like, if I were to create my own dream platform, what would that look like? So what are the things that I think are most important when you are looking at creating a remote imaging program at your facility? You're wanting to adopt and utilize remote scanning to benefit your operations and your team. So does that sound fair? And I'll just walk through kind of what.
Yeah, I think
Okay.
that's perfect. Yeah, I'll take notes for sure.
Okay. Yeah. So this would be specifically for me. I would not have a physical KVM. So I think there's vendors that still use a physical KVM. What I've found, as opposed to like a software KVM. The KVM just stands for keyboard, video, and mouse. It's how the remote technologist controls physically the mouse and keyboard of the scanner. The KVMs are an additional point of failure. They're an additional contributor to latency. And I just am not a fan. And I would never, if I was building my own, would introduce a physical KVM for those reasons. I've just had too many struggles with KVMs not working appropriately, causing us to be down at a facility.
That's the physical ones, right? Are you
The physical ones, right?
eKVMs, like the electronic?
eKVM, software KVMs, great. Yeah, no problem. So I would have my solution be backwards compatible with all vendors and legacy software versions. So whether the majority of imaging systems are Windows-based, GE is Linux-based. GE causes problems for everybody because of that Linux based software version, and only specific solutions are able to be backwards compatible with older GE scanners. There's some old Philips scanners that have driver limitations that limit some of the platforms from being compatible. So I would really look at, when I'm evaluating which one's best, if I have a diverse install base, I want my solution to be backwards compatible with all legacy vendors and software versions.
Is there a reality already, Derek?
There is reality. So there's two vendors that at least four, and so three vendors have published their validation, their systems that they're validated on.
Yeah.
Two vendors have not published that validation.
Just so everyone understands, the validation is basically your platform works with the version of a scanner, for example, Siemens, Aera.
Absolutely.
This platform works on that scanner, but probably won't work on the Symphony because it's quite old. That's what it means.
That's right. That's right. Yeah. So three vendors have published that, and so they say up front, here's the ones we work with, here's the ones we aren't working with, right? There's two vendors that have claimed, and I've not found yet a version that they're not compatible with, but they also haven't published any validation. So it's still, it's a bit of, okay, what we've tested on, it works for, but you've not provided me written, documented validation testing where I can go and say to a customer, 100%, these are the scanners it's validated on, right? So that's an important piece. And as far, I think to your question, Sam, is there a vendor right now that's compatible with all vendors and legacy versions and has that documented in a validation document? No, that's not. That document doesn't exist, at least that I know of today.
That's why it's your dream platform. So
that's why it's my dream. That's right. That's right. One thing that I do think is really important, on my dream platform, I would have, and I think all of these solutions are going to get to these things eventually, but two-way audio communication with the patient in room. So I want to be able to talk to and hear the patient and be able to have a conversation with the patient remotely. That's very important to me.
I tease you on this one because some scanners, GE, for example, I think United Imaging as well, they have their communication systems within the keyboard. If you don't like the KVMs, the physical ones, how do you see that solution working? Do we have to have a solution from the OEMs to change the way they do their keyboards and patient communication in order to use a virtual KVM? Or do you think there's a solution from the platform point of view?
Yeah, I think there's a solution from platform point of view that allows you to have a two-way speaker that's vendor neutral installed in the scan room. So you're not using the existing patient communication through the scanner because, like you mentioned, it comes through the keyboard on GE. That's going to be very hard for you to utilize, right? It comes through
basically the solution they have and provide your own solution within the platform.
That's right. And kind of the same thing for cameras, which is another must-have for me. I don't know if you've noticed this, Sam, but a lot of times patient cameras are installed on the outside of the
because of interference of the EMFs.
Yes, the Faraday cage, that copper mesh that's in the window that keeps out RF signals also does a very good job of keeping out my ability to be able to see the patient. So from a remote scanning standpoint, there's third-party vendors that have cameras that can be installed in the scan room, like right on the scan board. There's even vendors that have the ability for the camera to alert the technologist if the patient's moving. So I would love, in my dream scanner, to be able to have a camera fitted either right behind the bore or right in the front of the bore that's monitoring, that I can clearly see the patient. I can clearly see how they were set up, and I can clearly see if they're in distress, and also be alerted kind of proactively if I'm getting movement from the patient. So I can pause the scan.
You want a baby cam inside the scan.
Yeah, that's right. That's right. Yeah, baby monitor. So yeah, and then another piece, so once we've got those really good cameras in place, having those camera views integrated into the screen for the person that I'm actually scanning. So there's one solution right now, and I know they're addressing this, and I don't think it's out. It's been commercially launched yet. They did have it at RSNA, but they have their solution. So it has you on your view, you can see, multiple patients, but then the cameras are on a separate screen. And so the patient cameras aren't integrated into the scan feed from that scanner. So it's very easy as a remote technologist to be disoriented on, okay, if I'm scanning on 3 Esprit scanners, and I see this patient kicking their feet, which one of these scanners is the patient actually kicking their feet on, right? So it has to be, for me, it has to be integrated into the environment for that patient that I'm scanning. If it's not, it's a non-starter. Just a couple more. I prefer a VPN-free solution for the reason of being able to scan from home in a multi-tenant environment. So when I was working just for 𝐓𝐡𝐞, it didn't really matter. I could connect through a VPN because I was on 𝐓𝐴CuM's network, and so were all the scanners that I was connected to. But let's say if I'm a contracted remote tech and I want to work for 𝐓𝐴CuMin and also for RadNet at the same time, I can't really be operating on two separate VPNs simultaneously. So for me, I want to have a VPN-free environment that will allow me to be able to work with multiple locations simultaneously, independent of their network.
So it would be a
Wow.
cloud-based situation, basically.
Right. Yeah, exactly. Yeah, a cloud-based end-to-end encryption. I think that's even safer than VPN. So VPN just kind of anonymizes your IP address. End-to-end encryption actually encrypts that data. So if it's intercepted as it's being transmitted, you can't read it unless you have the encryption key. So only that remote tech is going to be able to see the information from the patient,
What
right?
you would be looking for is a P2P connection like WhatsApp, where it's encrypted when it
Yeah.
goes out and encrypted when it comes in.
Yep, exactly.
Okay.
Exactly.
I think we have opened even a new chapter, to be honest, because I didn't kind of like come across the idea of working simultaneously for two different providers of remote scanning. So I didn't even like encounter the problems of but the fact you mentioned it, that this is a possibility, is quite intriguing. I think it gives the idea of how advanced in some countries like the United States at the moment, or how quickly is progressing the remote operational thing.
It's an open field, Julian. You can be scanning with Ionic in one computer and WeScan on another one, and doing on the WeScan, which is Siemens scanning on a Philips scanner. It's an endless myriad of possibilities, to be honest with you.
I think you will be surrounded by laptops at some point. You will be essentially like
But you can,
rotating yourself.
if it's like Derek is saying, cloud-based, you can actually use one laptop and have two tabs with different
Oh,
platforms.
wow.
You can use those different platforms to, of course, I would advise to have two monitors, because with one monitor it's impossible to have two swap. But normally, if you're scanning more than one, you have two monitors, or three monitors if you're scanning three patients. Derek, please.
Yeah, so Sam, I have more dream, but I want to be, obviously conscious of time.
Fine,
So
yeah.
To the
yeah,
present.
yeah. So yeah, so if there's additional questions, I want to make sure that we get to those. But
Yeah,
yeah,
I
I
think
could I could keep talking about that for another 30 minutes easy.
I know. So there was a question here. Let me see if I can find. I have my own question, and Julian probably has his own questions as well. So Diogo is from Portugal. Is a friend of the channel as well. We met a while ago, and he's been visiting our webinars every single week. So he has. I have something I've been wanting to ask a couple of episodes back. Here in Portugal, most sites don't have anyone present that can reboot a chiller or a compressor if necessary. So the radiographer usually knows how to do it and troubleshoots most problems. We all of us have done it before. This question is: has something like this ever happened while working remote? And if so, how was it handled? Do you know any of these situations that have like power cuts and things like that? Who fixes that if it's a tech aid? Do they have training on that?
Yeah, so part of the tech aid training from some of these schools that provide tech aid certifications is equipment maintenance, is understanding what the gradients are. Like they've really boiled down the technologist skill set and knowledge to include everything except how to scan. So those kind of things like safety, like booting up the system in the morning, turning it off, addressing chiller issues, doing a TPS reset. Like they've helped them understand the pieces and parts around how do we make sure that we are able to address any type of service related issues that are occurring, just as if we had a technologist on site. So that's number one. Number two is, if you're connected to a remote technologist, that technologist is likely very familiar with that system and can walk you through how to do a reset on the system. Finally, if you have what I'm seeing from a lot of hospitals, networks, or outpatient service providers, is they are providing remote access to their third-party service providers. So if you have a system issue where the system stops scanning, instead of placing a service call, waiting for an hour for somebody to call you back, and then 4 hours for them to drive there, flip one switch, and then you're back up and running, they're able to troubleshoot remotely, look at the scanner, look at all of the errors that have occurred, and really walk that technologist through or the tech assistant through if something can be done locally on site to address the issue, to minimize the impact on patients during the day.
I think that's a great answer, to be honest.
Great answer.
Go
Absolutely.
ahead, please.
No, I was just saying great answer. Yeah, I really did like the answer he provided, and I think you always need to adjust on the way, as you said, and think about what could be potential solution. But it's a great question as well from Diogo, to be honest, because we need to think about everything. We need to think about all the potential scenarios and what might go wrong. And I just want to ask like one final question from my side, and then I promise I've closed my mouth. Because I think having you here, Derek, with experience like multi-vendor experience, I think you can also be like you can also testify the importance of education, not only from a scanning perspective, but from different point of view. So what are your recommendation from an educational standpoint to be quite, skilled enough to approach different scanners, perhaps in a remote setting as well, with different interfaces, with different software? Do you think perhaps this simulator, which is becoming like more and more popular these days, is it quite like a useful tool? Is there anything else you feel you would like to recommend?
Yeah, so when we look at how do we improve the clinical skill sets of current technologists that may be working for you, I think is the heart of your question, Julian. So are there, and I'm very familiar with the simulators that are out there, and they do a great job, kind of period and stop. Also, I think there's a huge opportunity to utilize remote scanning to improve the cross-training for technologists that are within your enterprise or within your, for instance, if I have a command center, I can have a brand new tech show up on day one to the command center. They can work with a remote tech, and that remote tech can connect them to any scanner that's within their enterprise. So in one day, instead of having to drive from site to site to site to get that training, in one day, they could get experience on a GE and a Siemens and a Philips. And when you think about what are some of the things that limit our ability to cross-train technologists quickly, sometimes it's maybe the facility that we're going to has a poor patient mix. So maybe you send them somewhere to train, and all they see is neuro exams all day. It's brains and spines all day. They never see shoulders, they never see knees, etc. Right? Or maybe you go to a facility and that facility it's a single modality facility. They only have one scanner. It's an OGE, and that tech is going to spend 3 or 4 months there, probably learning how to scan on the GE and not have gained any skills on any other vendor. Or I guess the last one is maybe the site that you go to is just very low volume. So you go to train at a site, the site only scans 6 patients a day. You need reps in to get better at something. And if you're not getting reps, you're not going to get better. So what that kind of command center environment allows is a training technologist to come in. They can see any type of scan that's done across your enterprise. So they're not limited by location as to what type of exam they're seeing. They're absolutely, volume isn't going to be an issue because on one of your 5 connected scanners, you're likely going to be scanning a patient. So they're going to be able to get exposure and get repetitions in, becoming a better technologist faster. And then finally, you're not limited to the physical location scanner type, you can, if you have 3 different magnets, a Hitachi, a Siemens, and a Philips, you can train on all of those in the same day. So it just greatly increases
Absolutely.
the efficacy of training and the
Yeah.
speed at which you can get technologists trained, and they're sitting there with a remote technologist who's likely a very good tech as well, providing them that training, right? So
Yeah, we got actually an example about this, Derek. We spoke with Zoe from Australia, and there is this fantastic role of the EMR supervisor. So she can dial in at any time to provide troubleshooting, explanation how to optimize a protocol. So I think, yeah, that, as you said, I think it's kind of like fitting what you're saying. These are fantastic opportunities for training,
yeah,
which the remote scanning is actually opening.
I think
yeah,
we
that's why I'm surprised that credentialing bodies like ARRT have pushed back so hard against the ability to be able to use remote competencies towards your required clinical competencies. So they're not accepting any, which to me, I mean, once you've completed kind of your patient care portion of your clinical education, why does it matter where I'm sitting if I'm scanning patients? And especially if I'm able to scan 3 times as many patients, if I'm working from a remote scanner and I'm getting so much more exposure to patients and exam types across the enterprise for the facility that I'm working at, why does the ARRT care if I'm sitting in front of a PC with a keyboard and a mouse, or I'm in front of the scanner with a keyboard and mouse? Like, it's the same. It's once you've done your clinical competencies around patient care, it's the exact same thing. So I don't understand their stance, and I think they're going to have to change it.
we had that conversation at RSQS, and was one of the main points for us as well, because it made no sense at all.
Yeah.
We're almost done, Derek. I have one more question, but before I ask you that, I think what we're talking about is the fact that we as radiographers, technologists, we've been kind of a passive professional within the radiology or within the healthcare world. And with the AI and remote operations and all of this, we taking over our profession, and we becoming not passive but active professionals. We deciding what we want to do, where we want to do it, how we want to do it. And I think that's one of the beautiful things about remote operations, is giving that power back to us. We can decide who we are as a professional, and not let everyone tell us you're going to be a GE operator for the rest of your life. So I think
Yeah.
it's
No,
one of the big points. So my question before we say goodbye, because I know you have to go, where do you see the biggest growth opportunity for remote scanning in the next 5 years? Is it rural access, outpatient, cross-state scanning, cross-country, cross-continent? Where do you see it coming from the next 5 years? In a few words.
yeah. So as far as cross continent, Sam, I don't really have any great insight into those opportunities, because my focus is primarily in the U.S. So I know that a lot of your of the audience here is international. So hopefully you can chime in a little bit on the back half of your question. But certainly, I think growth opportunities in the U.S. are, and what I see over the next 5 years, I think that for most outpatient facilities that are not hospital-based or academic centers, technologists are going to be demanding that they have the opportunity to work remotely. And if you're an employer of an outpatient facility, whether it's a large outpatient group with 100 scanners, or you have 2 or 3 scanners within your practice, they're going to have to figure out, how do we make this work, because it's going to be a demand from the labor pool. I think that the majority of technologists are going to want to have that ability to be able, and technology is allowing them the ability to be able to work remotely, to work from home. So I think that's probably going to be the biggest area of growth in outpatient radiology, where, to your point, technologists are starting to take control of their own careers and career paths, determining where they want to work, for who they want to work, when they want to work, what rate they want to work for. And employers are going to have to provide accommodations to those, or else they're going to have an even harder time finding technologists that are going to scan for them. And not every place and not every facility. It's not right for everyone. But I think there's going to be a huge growth over the next 3 to 5 years in the demand by technologists to be able to operate remotely.
Perfect. Derek, thank you so much for this. I think it was a very enlightening conversation for everyone, for me as well. I always learn from all the guests. So thank you so much for being here today and sharing your knowledge and sharing all this information. I think it's really, really good. Julian, do you have any last words before I share something as well?
No, I just want to say thank you so much, Derek, as Sam said, and thank you also for everyone who attended today. I think there are people that have been attending each single
Yes.
webinar of this series, and I have to say we have actually a little surprise for you, because today, Everything MRI, after 2 years from the very first day we decided to open our social, we got like a sort of achievement. We achieved like the 20K supporters on LinkedIn, which I think is a great
That's
result,
amazing.
especially because we've been a small company and always like fighting, to find our spot. And because of this, next week we will have a little surprise. So stay tuned. Just pay on attention our social. There will be something you might like. That's the only thing. But thank you so much again for attending tonight.
Of course. No, it was absolutely my honor. I have so much respect for what you guys are doing in the industry and for the industry and for technology. So thank you guys.
Thank you. Before we leave, I just want to communicate that the next webinar is not on Tuesday, it's going to be on Thursday. Unfortunately, I'm going to be in London, and me and Julian will be recording podcasts, and I won't be able to do it on Tuesday because my flight was changed. So we'll have to do it on Thursday, and we'll have Geraldine Fernandez. As I said, it's going to be all about safety. So if you have questions about safety within remote operations, Thursday next week will be the day to ask everything. Geraldine will be here with us. She's an MRSO. She trains tech aides on their daily basis in terms of being a local operator. So I think it's going to be a very, very interesting webinar as well. So once again, thank you all for being here. Derek, thank you so much for being the person you are and for doing what you're doing for the community in general. We appreciate you, and have
Of course.
everyone.
All right. Thanks, everyone. Bye.
Thank you,
Bye-bye.
everyone. Thank you so much. Thank you.
Bye.